Okay, Professor Kim, I can't see your slide, right?
Okay, okay. Some give me a minute. Okay, could you see?
Okay,
Could you see the
yes,
slide?
yes.
Okay.
Now it's perfect.
Mm.
Okay, let's get started then.
Oh, okay. It's time's
Uh,
up. So,
okay, I'll begin the introduction.
okay. Hmm.
Okay, hello everyone. Welcome to the 111th ICC webinar. And my name is Junior 2, and I'll be moderating today's talk. And today we're very happy to have Professor Baek-Kyu Kim to join us to give us a talk on comprehensive solutions for cleft nasal and lip deformity, a multi-dimensional approach. And Professor Kim is actually a faculty member at Seoul National University, where he trained his residency. And also, he is currently the director of the Academic Affairs Committee in the Korean Cleft Palate and Craniofacial Association. And he is also the director of the International Affairs Committee at Korean Society of Plastic and Reconstructive Surgeons. And now today we also invited three esteemed panelists. First is Dr. Joseph Low, and he is from the Joondalup Hospital in Australia. And our second panelist is Dr. Takafumi Saito, and he is from St. Luke's International Hospital in Japan. And our third panelist is Dr. Sarah Youth, who is from Mahidol University in Thailand. So without further ado, please let us welcome Professor Kim.
Okay. Yeah, Dr. Junior too. Thank you for your very kind introduction for me. So it's my great honor to be here as a presenting the International Craniofacial Conference. So today's my talk is about the comprehensive solution for the cleft deformity and multidimensional approach. So actually, my experience a little short, and so I try to my best to share my experience, and please give me any advice can help the other beginners and then for me. So today's beginning to begin to my talk, I want to talk about the 3D dimensional structural component of the lip and nose and alveolus. Uh, as a plastic surgeons, we should uh, adhere the every component of the structure of the organ. So, lip has a oris muscle, and then the alveolus is a bone, and then the skin and mucosa is a envelope. So, we should consider all of the component. There's a deficiency or any uh, error of the anatomical arrangement. So, I from my experience, I realized that if there is a deepest uh, the deepest status is not normal, any additional surgery over the around the outer surface is uh, incomplete, and that is very inappropriate procedure. So every patient when I met. I'm trying to evaluate if there is any deficiency of the structure as like a muscle or the bone. So if there is any remained abnormal insertion of the muscle, we should correct it as an incomplete cleft form. And there's any volume insufficient volume of the bone, we should refill it as an additional graft with any bone graft from the other side. And then the last one is that the outer surface, if there is any landmark absence or that profile imbalance, we can correct it as a final stage. So yeah, this is a very typical case as the cleft deformity. Actually, this patient lip is very similar to the incomplete form. So this patient might be corrected as a lip adhesion. So I try to the lip surgery again, the release of the all of the abnormal insertion from the any site from the cheek and then ANS, and then this is the final immediate post-op, and this is the 1 month post-op. So to evaluate the lip shape, we should check that abnormal insertion of the muscle that fully dissected and released to the normal sling shape. So this is a diagram illustration of the our article. So we are trying to the full uh, reconstruction of the muscle sling from uh, the most lower side from the most superior side. So I think this most superior margin of the muscles repair is very important. So if there is no, if it is not appropriate and then not enough, then the muscle deficiency maker nasal base depression. So this is a very essential step uh, in the first surgery and then the correction in the correction of the secondary deformity surgery. And the other is that if the muscle restoration is the complete and then that is enough, then we can move to the outer surface coverage. So I'm trying to cover the all muscle superior margin with the yeah C flap or the B flap. The reason is that B flap is that I trying to feel that columella base with the C flap, and then the other is M flap is that the nasal base, and the L flap is the posterior side of the muscle. So this is the final step of the repair of the B flap or C flap with the M flap. That is the lining of the nasal base. So this should be very watertightly repaired to evade any secondary correction, secondary contraction from the any outer surface defect. And then the other step is that we should check that is there any improper landmark assignment. So in this case, we can see that any the irregular margin of the cubic bow peak and then notching of the red vermilion margin. So uh, we should reassign that lateral lip, the cupid's bow point, and then the remain. We are trying to remain the skin flap as a releasing of the end flap of the oral mucosa, and then feel we can use the end flap as a feel that the mucosal defect. That's our strategy to correct the landmark um, abnormality. So this is another case. You can see that the stepping of the cubital peak and then severe notching or fistform deformity of the red vermilion. So we rearrange the oris muscle again, and then you can see the most utmost superior muscle of the lateral lip to trying to anchor to the columella base or the septum. So this is the immediate post-op, and this is 1 month after. This is a very usual cases like a microform. So you can see the divided cupid's bow peak. So this is the pre-op and then the post-op 1 year. You can see that rearrange the cupid's bow peak landmark. And this patient is already several underwent the several operation in our team, but she got the rhinoplasty and then got a scar vision, but she complained about the deviated the medial cupid's bow landmark. So we trying to relocating the orbicularis oris muscle sling to detach all hole from the adhesion and then uh, adhesion site, and we moved as a as you can see as a VY incision, and we whole release of the oris muscle and reattach to the ANS is a very firmly. So this is a pre and post 2 months later. So her the median cubital line is a little corrected. And the final is that the scar and the contraction. So the scar is that every the cleft patient after the first lip surgery, the scar is that uh, every patient has a scar. But if the scar is positioned on the landmark, and then it can hinder the normal understanding of the landmark, we should correct it. So this patient got the rhinoplasty as well, and then you can see that scar revision, and then we can reattachment of the deep, incomplete repair of the orbicularis oris muscle from this horizontal approach. And this is a pre and post. And this patient, this young lady patient has a depressed scar at that right cupid's bow peak, and then fusiform deformity. So we reduced. Actually, this patient main problem is that malassignment of the lateral lip, the cupid's bow peak point. So we are moving to the more lateral, and then muscle repair gain. This is the pre and post. And this patient, you can see that the picking deformity of the right cubital peak, and then a little depression of the scar contraction at the right red bomerion. So we correct this as a scar revision, and then muscle repair again. You can see that the much convex of the red bomerion volume, and then effacement of the scar. So yeah, moving to the correct rhinoplasty for the nasal cleft. So you can this is very famous, and everybody in this Zoom maybe we are all know this maneuver, the Tajima correction. This is a very famous one. Then how the Y dissection, and then anchoring the lower lateral cartilage to the more superior and medial. But to do this maneuver, we should check that if there is any skeletal deficiency of the nostril base. If there is a skeletal deficiency, we cannot correct the uh, whole shape. So the cartilage weakness is the next problem. And then if there is any skin excess at the nasal base, that should be correct with the in the rhinoplasty courses. So yeah, we know that if there is a weak base, that the building should be slant again. So we publish this article as a uh, very simple method to fill that nasal base skeletal deficiency with the Bomo bone. So during the rhinoplasty, we can get the Bomo bone very easily. So we can position the body Bomo bone as a spacer to maintain the nasal base. So this is a pre and post. So we can see that well elevated nasal base. And this is another case. During the rhinoplasty, we can get the bomber bone with the cartridges. So we use the cartridge as a rhinoplasty, and then the bomber bone as a filling the filiform aperture defect. So this is a pre and post. And this is another case. You can see that severely depressed nasal base, but we feel that the bone graft has a leveling the nasal nostril base. This is another case. You can see the nasal base depression is well corrected with the bone graft. Yeah, this is another case, and the same method. So I choose this method if that patient doesn't need to the bone graft for the alveolar cleft. If the after alveolar cleft correction with the iliac bone or the cranial bone, the filiform aperture defect usually remain. So in the case, the bone bone very usefully uh, very useful method to fill it. Yeah, this is another method, another case for the fill the left side nasal base. And this this middle-aged male, uh, he 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 underwent the hemi-Lipoton advancement. This patient's the maxillary arch was severely depressed, so that any bone graft doesn't uh, enough for that fillet. So this is another yeah case for the correct of the nasal base. And then if that skeletal base is confirmed as a leveled and then well elevated, then we can move to the a la cartridge correction. So I'm trying to reinforce the weak cartridge as a strut as a with the turnover flap of the lower lateral cartridge. So this patient was trying the lateral crura strut graft and then canaloplasty again. So this is a pre and post. And this patient is, get the wear excision simultaneously, and then the cartridge augmentation, the cartridge firmness augmentation. Okay, this is a pre and post. And this patient as well. You can see the immediate post-op, the lateral crural strut for the reinforcement of the firmness. And this is a immediate post-op, and this is a post-op 1 year and 2 months. Yeah, this patient has got the lateral crural strut as well. This patient, the same method. So this patient's a very extremely a difficult case. As you can see that cleft side is nostril is very small. So uh, I think to correct it, we should correct the normal side, reduce reduce method. But this patient only expanding the nostril as a cartilage reinforcement. This is another patient. It's the left side. You can see pre and post. This is the comparison. And this patient also the feature of the buckling and then very weak cartilage. This is a post-op. And this patient also has a very small nostril and then collapsed nostril. So we try to the arterial strut to expand the nostril. This is another case, the same method, pre and post. And this patient, has a collapsed nostril was expanded with the lateral crural strut method. This patient has a same technique used. And so this is a third aspect to correct the nostril. If there is any nostril base has a excess of the envelope like a skin, we should reduce it by chinching or excision. So this is you can see that this patient very wide nostril dimension. So we reduced as a excision and then chinching. This is a post-op 2 years pre and post comparison. And this patient has a very weak cartilage support, so very wide nostril base. So we correct it as well. You can see the nostril shape change. And we are moving to the bilateral. So I think the bilateral cleft deformity is a very it's not easy and very challenging uh, to every cleft surgeons. It has a horizontal excess with the vertical deficiency, and then as you know that every bilateral cleft deformity has a flat and concave facial profile. So this patient complained that crooked nasal tip and then central notching and then wide that pectoral shape. So we are trying to correct it all as a muscle repair gain and then using the septal cartridge, the tip graft. So this is a post-op. So this is pre and post. And so this article is from the other team, but as you can see the diagram of this article, this the authors of this article focusing the same approach. So they reduce the horizontal excess and then augmenting the vertical height. So yeah, this is that every cleft surgeon could agree that this approach. So yeah, this is another case of the bilateral cleft for rhinoplasty, the tip augmentation and reduce the horizontal. Yeah, this is the same. So I'm trying to the augmenting the dorsum and tip simultaneously. So this patient, young lady, has a very collapsed nostril. So we are corrected using the rib cartilage graft. This is a pre and post. And yeah, this patient also has a severe buckling bilaterally. So corrected as a rib cartilage graft, T-plasty and dorsal augmentation. And this patient has a very flat nasal dorsum, like a Binder syndrome. But yeah, this is caused by the bilateral cleft. So the pre and post and using the rib cartilage graft. So the profile, the last step is the profile. So every deformity corrected, we should correct the profile as well. So this bilateral patient, you can see the very concave shape of the profile. So we could correct it the orthodontic surgery usually. So but we are approaching the profile with the orthodontic or the rhinoplasty. So this patient has a bilateral microform. So we are trying to repair with the uh, r- with the rhinoplasty. So you can check that corrected the crooking tip. And then this is another patient. This patient's the first and second and third photo. So between the first and second, this patient underwent the orthodontic surgery, the two jaw. So Lupotone advancement and then uh, mandibular setback. But the patient doesn't yeah, he wasn't satisfied with the result, so we did the additional rhinoplasty. You can see the uh, improve the profile with after rhinoplasty. This patient the same after first orthodontic surgery. Uh, she thought yeah she was not happy, so she was not happy, so we did another rhinoplasty. Yeah, this patient also after orthodontic surgery, he need another. He wanted additional surgery, so we did the rhinoplasty to correct his flat tip, more convex profile. So yeah, this patient the same after the orthodontic surgery. Uh, he complained about the crooked tip and flat tip, so we are corrected with the rhinoplasty. So this is the yeah change of the profile. So this is the last case with the operational video. So yeah, he was bilateral cleft deformity too, and he he wanted to correct the malocclusion. So after orthodontic surgery, but yeah, as the same the previous cases, he wanted to additional profile improvement. So this is the operational video during the rhinoplasty. We decided to do the open rhinoplasty, and I'm trying the rhinoplasty using the very sharp seizure and then bipolar. So as you can see here, the lower lateral cartilage is diverse and then very flat, and so to correct this, we need the form support and augmentation. So I decide to lip, lip cartilage graft rhinoplasty, and this is the lip cartilage harvesting procedure. Uh, Usually I'm 3.5 centimeter incision, and then after incision, I'm the suprafascial dissection more uh, to to get more surface, to more space, and then perichondrial incision, and then perichondrium exposure. Yeah, so after the bilateral margin dissection, and then under the lip cartilage dissection, we can get the lip cartilage without any injury. Uh, the without injury, the harvesting without injury is very important. Yeah, everybody knows that if there if happening the injury that make a warping or the weakening of the cartridges, so cautiously dissection and then incision to uh, the continuity area with the blade, and this is the yeah undersurface dissection, so we can get around 5 centimeter length cartridge usually with yeah, this procedure. So the to insert the dorsal augmentation, I'm trying to add this mass after the slicing very thin plate that make yeah, that prevent the warping. So I'm stacking several sheet of the slice the lip cartridge, and then yeah, get together using the PDS50, and then I'm inserting the implant in the dorsal pocket, and then to augment the tip. So the strut graft and then shield graft is performing now. Uh, yeah, this is my usual maneuver to get the high profile, and then yeah, this is the wing graft to uh, prevent any depression of the soft triangle. So after rhinoplasty, uh, I'm trying, recently I'm trying to get the three-dimensional shape of the philtrum. This is that actually this patient's scar at the philtrum, yeah, was not bad, and then almost effaced during the several years after the first surgery. So I'm just trying to getting the filter dimple in at the center. So I'm trying to the dissection under uh, the skin, without any incision over the skin. So to dissection as like this, we can make a space under the between the skin, and then okay. So after make a space, I'm moving to the wear excision. So every bilateral cleft has a very wide skin excess at the nostril base. So the wear excision, and then I'm trying to chinching suture. Just the wear excision, not enough to reduce or that is the one first reason, and then the second reason is that by doing the chinching suture, we can make some depression the center of the philtrum. So yeah, this is the after getting through the 3O PDS and through the center point, and then I'm getting the same point again to the opposite side, and then anchoring the ala base, and from uh, left ala base to the opposite side, getting through again. So by doing this, we can make her one the PDS sling as anchoring the central point. So the central point anchoring can make her the filter dimpling at the superior side. So this is the after the the chinching suture, and then the reduce of the horizontal horizontal length. Then I I think that the functional dimple should form at the most lower point, just superior the central cupid's bow. So there is a uh, same method. So there's a central point slit incision. So from the central point incision, I through the two uh, yeah, but the bilateral needle, the 40 or 50 PDS. So that's the maker anchoring at the dermis. And then I'm trying to the two needle as a the muscle the re, re, reattachment again. So yeah, this is the course of the anchoring the central dermis just over the just below the cupid's bow and anchoring the both side of the oris muscle. Actually, this is a very yeah similar maneuver as the ala chin sling, as you can see that. Okay, yeah, this is the final, and then just a repair of the just yeah. After repair, the operation is completed. Okay, so this is the after 6 weeks. So there's some redness remained, but he satisfied with that augmented nasal profile and then formation of the philtrum. This is the first, and then uh, the first is the before orthogontic, the middle is the after orthogontic, the third is the after rhinoplasty. Okay, so this is the final slide, and then my take-home message. So I think the cleft is a central defect with the dispersed tissue. So the bilateral has a more the double these features, and so to correct the deformity of the cleft, we should bring the muscle and bone in center again. Maybe in the first operation, that the surgeon could have some errors, so we should imaginate what is the error of this deformity, and we should correct again. And so I'm trying to get the convex and then full shape of the lip and then nose. So that is important to correct the deformity. And so the final uh, objective to correct the cleft deformity is that convert the cleft stigmata to the normal anatomical features. Yeah, that is the take-home message of today. So I'm the most left photo is that me and my mentor, the Professor Longmin Baek. So I followed him during almost 20 years, and he visited the every other Vietnam and then Myanmar and Indonesia. So that's a very big education for me. And I'm going to the Laos as well nowadays. So I'm deeply appreciate this opportunity to and hold the teaching from him. So yeah, thank you for careful listening in the very late evening. So if you have any question for me, you can ask me freely now or by this email. Thank you.
Thank you very much, Professor Kim, for this amazing lecture. And also thank you for sharing with us your very valuable videos. And at this time, I'd like to invite our panelists for some comments. So first, I'd like to invite Dr. Joseph Low for some comment. Joseph?
Yes. Hi, thank you very much, Professor Kim. Really appreciated your lecture and the very many principles that you shared. and I'm very impressed by the results that you have achieved. So, congratulations.
Yeah, thank
And
you.
yeah, I just had a question just on the vomerine bone
Boomer bone
graft.
graft. Yes.
How exactly is it placed? Is it kind of placed the same way people place a dice cartilage, like an onlay? And then my follow-up question is then, what is your thoughts on the vomerine bone graft, it kind of long term in preserving or in correcting the nostril base deficiency?
So you mean that the long-term follow-up or mm.
Yeah, long-term outcome for the vomerine bone graft, and also want to clarify how you place the bone
Okay,
graft.
okay. Yeah, okay. I totally understand. So uh, every patient has the deficiency of the piriform aperture skeletal volume. So I'm trying to the dissect the mucoperiosteal flap, and then we can check that very severely depressed, or in many cases we can check that remain the fistula. So if there's remain the fistula, we should fistula repair the first, and then we just repair of the mucoperichondrium is not enough. As you know, that some dead space filled with the hematoma it's naturally contracted again. So I'm trying to use a bone bond to prevent the secondary contraction. So it's just the spacer. So uh, in the article I introduced today, that's around that between the 10 or the 15 cases, only very small cases. So I cannot exactly comment that how was the absorption rate, but maybe, yeah, maybe the absorption in the iliac bone graft for the alveolar cleft, that absorption rate is the presented in the some percentage. So I think that uh, uh, the bone graft is autologous, and then it's definitely better than any artificial grafts. So I could recommend this method as a just the additional or the adjunct. There's a small assistant maneuver. This is not any definite as like a iliac bone graft, but uh, I think that it could act as a some spacer if you can repair the mucoperichondrium of the mucoperiosteum of the nasal base. So yeah, this is my thinking about, yeah, this bone graft method.
Great. Thank you very much.
Mm.
Okay, thank you, Dr. Joseph. Next, I'd like to invite Taka for some comments.
Oh, thank you, Dr. Kim. Very nice presentation. I have a question for upper lip deficiency. In my usual the clinic, I think it's very difficult to augment upper lip regularly. So, which surgical procedure do you prefer to augment upper lip?
Upper lip, upper lip. Yeah, very good question. Yeah, very good question. So, as I introduced in my cases, some patient feature the central lip deformity as like a fissure form. So, I think uh, that approach to correct it, we should release the abnormal insertion of the oris muscle again. In every cases I experienced, uh, fusiform deformity is induced by yeah the under rotated the oris muscle. So if you could do the muscle approach again, and then release the muscle from the ANS, and then it's like this. This is the medial and this is lateral. So you can rotate medial muscle again. It's like this. So by doing this, you can get the central tubercle again. So that's my opinion.
So you mean to augment your the upper lip volume, you use the muscle reconstruction.
Yeah, right. But
Um,
mostly after muscle reconstruction, that patient needs another augmentation. We can try the fat graft or the normal fat graft.
okay.
Yeah. Just central defect is that definitely muscle, muscle deficiency or that undercorrection of the muscle sling. So
Okay. So you mean you do the muscle reconstruction in first surgery, and
mm.
if not sufficient, you move to the second surgery, which is
If
part.
the lip shape is normal,
Hmm?
there is a present some central tubercle and then full shape of the white roll,
Mm-hmm.
then you can try the fat graft. Yeah, I
Okay.
think fat graft is the best
Thank
in
you.
the normal shape. But
Yeah.
shape is incomplete. You should rearrangement of the muscle again. Yeah.
Okay. I understand. Thank you, Professor.
Thank you, Dr. Taka, for your comments. And last but not least, I'd like to invite Dr. Sarah Youth.
Yes, Professor Kim, thank you for sharing us your beautiful result. Your lecture is very informative to us. Thank you very much. And I agree with you that the muscle arrangement and muscle repair is the landmark or is the hallmark of the normal anatomical arrangement. So I have two questions for you. That do you have any experience with the dice cartilage for the dorsal augmentation?
Oh yeah.
And do you have what is your opinion about it?
Okay. So in the Korean, the Rhinoplasty Society, the dice cartridge is very usual and then mainstream. So uh, if you could join the SRF, the Seoul Rhinoplasty Forum, you can get many information about it. So it's a very as I actually I thought I do not use that method. Just I'm using the sliced, but the dice cartridge is very useful. And then if it used as a very secure method by the Dr. Mangun Seo. So he recommended very is a very maintainable and its absorption is a little low. So yeah, it's a good method. Yeah, if you could try.
Okay, so my follow-up question is that do you have any experience with the warping of the cartilage
Warping, yeah.
when
So
you use
the
the sliced
right,
cartilage?
right. So before using the sliced, I have maybe over the 60 or 70% complaint about the warping. Just one piece cannot, uh, yeah, cannot evade from the warping. Is that inevitable? But after slicing, maybe the slicing means that warping can induce the superior or inferior. So I stacked every layers so it can warping force can act as a to each other. So by doing the mechanism, the warping cannot happen in my method.
Okay, so do you have any cutting direction,
Oh no.
the specific cutting direction that prevent the warping?
Oh yeah, right. Yeah, prevent warping. I'm using the slicing method.
Okay, that's all for me. Thank you very much.
Okay, thank you, Sarah Youth. And at this time, I'd like to invite Professor Low for some comments.
Yes, Dr. Kim,
Yeah.
very nice to hear your talk, and your result is pretty nice. Uh, First, I have to say that the secondary credit nasal deformity is quite complicated and difficult
Right.
in the sense that many surgeons have a different technique, a different approach to correct the problem. And today I saw your method is pretty nice. And also I would like to emphasize your concept of muscle repair. And also I do muscle reposition or muscle repair in the secondary chronic nasal deformity. I think it is quite important to correct the muscle. Muscle is the almost the important part or matrix in the lip morphology. So this is one thing I would like to emphasize. Second thing is alar base depression. Certainly, for some secondary deformity, if the primary was not done well, then you see the alar base depression. And the alar base depression, I saw that you use autogenous bone to augment the alar base. Is that correct?
Yeah, right, right. Yeah.
Okay, because I personally I do not use autogenous bond. If I really have to elevate the alar base, first I can redo the lip repair, elevate the whole alar base, and use the muscle force to support the elevation. Or many times I will use so-called the allograft because allograft is non-absorbable, and that is also very effective to elevate the alar base. However, in my practice, I don't have many patients with alar base depression because we do have very good primary repair. So this is second comment. And the third thing is I would like to hear your opinion is that for the nasal tip control, okay, I saw you use mostly the strap graft, right?
Yeah, yeah,
Cartilage strap
and
graft
then shield graft.
to shield graft
Yeah.
to control the nasal tip. I wonder, do you use so-called septal extension graft to control the nasal tip?
Yeah, that's a very good method, but in my case is that I usually using the septal extension or the derotation graft to do the yeah to the derotate as in the contracted nose, but every the cleft patient has a little crooked tip or the a little long nose shape is the main cases. So I'm just using the strut is the only method.
So in your practice, you see that many of your patients have longer nose,
Yeah, right. Yeah.
not shorter nose.
Yeah, I shouldn't know.
Oh, okay. Because in my practice, my patient mostly have a shorter nose, maybe, so I have to lengthen the nose by about 3 millimeter for each case. So I use a lot septal extension graft instead of strap graft because in my hand, I feel that septal extension graft can control the tip
Right.
position and definition quite well. So this is my comment. But anyway, I think your result is quite nice. And thank you and congratulations.
Thank you for very good advice, Professor Low.
Okay, thank you, Professor Low. And now at this time, I think we will move on to our Q&A session, and we have several questions raised by the audience. So the first question is from Dr. Caesar, and the question is, how do you treat nostril stenosis in unilateral cases?
Yeah. That's a very actually that's I think that's the most difficult problem in the unilateral case is that severely contracted nostril. So that should be evaded at the first surgery. But if I met that cases, I'm trying to that expanding to the superior using the Tajima or that any lateral strut reinforcement. And then I'm a little expanding the lateral ala as a VY, but that's limited. As you can see that, as we know, the lateral drift is very difficult and then almost impossible. So the final step is that reducing the normal side of the nostril. So by doing this, we can reduce the any big difference of the nostril width. Actually, nostril height, increasing nostril height is not so difficult, but width is a very, I think, is a very big problem to us.
Okay, thank you. And our next, we have two questions from Dr. Kazubi. And the first question is, in your presentation, you demonstrated a surgical technique to correct the midline deviation of the lip. Could you please provide more detail about the procedure and explain the anatomical background?
So that case I showed you, that patient has the same ratio of the center of the cupid's bow and then cupid's bow peak. So in that case, we cannot adjustment of the cupid's bow line, but because of the problem, but we can move the whole muscle. So uh, to correct the patient main complaint, I'm trying to approach the upper labial gingival sulcus, and then I detach the whole the oris muscle from the bony adhesion site, and then it's like a free flaps, it's like totally elevated and then moving, and then the make a hole at the ANS, and then I anchoring the muscle to the uh, in the median position. So that's my operating steps, and then actually this is my only case. The other patient, actually some candidates presented, but other patients just satisfied that just a normal shape. But the the young female patient I introduced today, she is very delicate, and then she really wanted to relocate over the median. So because of the her needs, I tried that method at that time.
Okay, and our next question, also by Dr. Kazubi, is that for Eller-based deficiency, he often uses coastal cartilage grafting. However, after several years, he noticed that there might be slight relapse, which may be due to resorption or soft tissue changes. Now, in your presentation, you showed the use of Vollmer grafts. Now, since bones may undergo even more severe resorption with Vollmer bone graft, how do you address this problem in your practice?
Yeah, right. So the Dr. Lu commented the same thing at the first. So every graft at the piriform or the paranasal area could be observed, because we every surgeons know the fixation is the most important step to prevent obstruction. But this side is a always move. We can, during speak or eating, this is a very moving area. So actually, I tried it to the screw fixation or the other very firm the repair that to prevent any moving of the graft. But as I evaluated, around half can cannot cannot prevent the absorption. So every cases I'm doing this procedure, I want, and then I had a permission to the patient if there could any absorption can be happen. So in that case, we can try again, or the fat graft or the other augmentation method. I think that's a only method to uh, uh, the so that the patient doesn't be disappointed.
Okay, thank you, Professor Kim. And that was the last of our Q&As. And now, before we conclude this talk, I'd like to share with you just our Chang'an Forum. Because this year we're again hosting our Chang'an Forum, and it will take place here in Taoyuan Chang'an Memorial Hospital from September 29th to October 1st. So if you're free, please join us for this event. And this year, the main topic of this year's forum will be maxillofacial and secondary cleft deformity, functional and aesthetic restoration. And we have 3 days of very um, well uh, educated programs for everyone to join. And there will be lectures from Professor Yuri Chen, lecture from Professor Daniel Huang, and also from Professor Low. And also this year we will be holding live surgeries and that everyone can see. So we'll demonstrate how we perform these surgeries, such as VPIs, ONFs, and even orthodontic surgeries. So if you haven't signed up already, please join us, and we hope to see you here. Thank you. And now, once again, I'd like to thank Professor Kim for joining us for today. And also, thank you, Taka and Joseph and Sarah Youth for being our panelists for tonight. Now, our next ICC webinar will be next week, and the talk will be by Professor Hutz, and he will talk about sleep surgery for OSA. So if you're free next week, please join us for this event. Now, everyone, please open up your cameras and we'll take our photo. Oh, it's good to see everyone online here. Hello, Ike. Hello, Fukui. And hello, Handa. And hello, Professor Huang. And hello, Hongshen. And hi, Abraham. And Harriet. How are you? Okay, so let's take a photo. I'll count to three. 1, 2, 3, smile. Okay, 1, 2, 3, smile. All right, thank you, everyone. And we'll see you next week. Bye-bye.
Thank you. Have a good night.
Thank
Bye
you once
bye.
again, Professor Kim.